Hello, I'm Dr. John Cruz, and today I'm going to be talking about rejection sensitive dysphoria in ADHD, and this was not timed to be delivered necessarily the day the election will be decided, but I think it's a fairly apt title for today or topic, and I will be talking for about 20 minutes. If you have questions while I'm talking, you can certainly type them in. I'll be available at the end of the presentation if there are more questions. And as a reminder, I am the author of Recognizing Adult ADHD, What Donald Trump Can Teach Us About Attention Deficit Hyperactivity Disorder. And hopefully, now that it looks pretty convincingly that he is out as president, maybe my book will be less toxic to many people who want to learn more about ADHD. So moving on to rejection sensitive dysphoria. So what does this big long term mean? The first part is sort of common English use. Rejection sensitive means that these are incidents that are happening when people are getting feedback that is rejecting, that's negative, that's criticism, that's teasing, that's commentary in some way, that's suggesting someone doesn't approve of you. And the title suggests that those people with ADHD are particularly sensitive to this type of negative feedback, and dysphoria is our fancy word for unease, generalized dissatisfaction with life, negativity. In short, it's a similar word to depression, but it's often a more acute or short term. It comes from the Greek word meaning hard to bear. So the concept of rejection sensitivity dysphoria has been strongly developed and promoted by William Dodson, Bill Dodson. I think he's still based in Colorado, psychiatrist who's been working with adult ADHD and child ADHD, I think, as well. For 30 plus years, he's on the board of the Attitude magazine and writes extensively there. And this concept has gotten lots of traction in the ADD community because it does explain something that they experience, something that is real, and something that has been, I'd say, neglected, particularly by the formal DSM-5 diagnostic criteria for ADHD. So again, this is a phenomena where when people with ADHD are criticized, rejected, teased, commented on negatively, they have an intensely strong negative emotion. The center of it is disappointment with themselves, intense shame, but usually it is so intense and powerfully emotional that often people have trouble finding words for it. They wind up being in a negative state, and that intense negative state can last for minutes to hours. So in the original writings by Dr. Dodson on this topic, he often brought it up in the context of sort of shame and stigma and societal disapproval of the behavior of kids with ADHD. And he popularized a observation. This is not a rigorous study by different psychiatrists, by Michael Jelenic, who's a Harvard associated psychiatrist, who wrote years ago that by age 12, a typical boy with ADHD is probably getting 20,000 negative comments at school in excess to what a normal boy at school is getting, solely because of the ADHD behavior. And again, this 20,000 number was not a formal study where they went and counted. It was sort of a back of the envelope calculation based on how many times those kids were likely to transgress rules, to stand up when they weren't supposed to be standing, talking when they shouldn't be talking, not paying attention in class, and other things, and multiply that by the days in school and a number of years before someone gets to age 12. So the original formulation was that this massive negative experience was a contributing factor to developing this hypersensitivity. Very clearly in the last few years, the writings I've seen by Dr. Dodson actually discount experience as a factor in this, and that they define this as a part of the hardwired neurobiology underlying ADHD. So some of the things that Dr. Dodson points out about it, that this is something that is often confused with. So one is almost a third of people with ADHD, if you ask them what's bothering them about their condition or what's their presenting symptoms, actually this strong dysphoric negative mood state is actually the top presenting syndrome or problem with many people with ADHD. So it's not the distractibility, it's not getting off track, it's not procrastinating in up to almost a third of people. Two, and I think he rightly identifies that many of these people get misdiagnosed, identified as having depression, because again, the intense negative state looks similar. And some of the criteria he points out is that RSD, or rejection sensitive dysphoria, is always a reaction to a stimuli. Now it's an overwrought, over excessive, intensely negative response to it, but it isn't just an out of the blue manifestation of negative mood. And at least some part of depression or mood disorders requires sort of some of the feeling state to not be entirely dependent on triggers evoking it. And the other big issue is the time domain, that for diagnosis of depression right now we require prevailingly, it doesn't mean every moment of every day, but negative mood for at least a 2-week period, whereas RSD is happening on a more quick time scale. So two other things that it's often confused with is bipolar disorder, where there can be some volatility of mood. But again, there are usually other elements, including elated, grandiose elements, decreased sleep, and a bunch of other things connected with either mania or hypomania, not necessarily there with RSD. And the one diagnostic category that I have not seen Dodson talking about that I say clearly, unequivocally gets confused or mixed up with this is borderline personality disorder, because that is a situation where people are overreacted to a range of different emotional stimuli and perceived rejection. And we know that people with ADHD are overrepresented in the borderline personality category, and I think there are many people who are misdiagnosed. You certainly can have both of them. Dodson also goes on to say that it sort of, in addition to sort of the shameful, negative, depressed aspect of it, it can also manifest more purely as anger. And again, this is, would make some people more prone to being mistaken with, or it could be confused with borderline personality disorder. And a statistic he brings up several times in his writings is a study that showed, at least one study, that among people who were mandated for anger management by a court, so they got into problems so severe that the law said you have to deal with this, up to 50% of them in one study were found to have ADHD, and the majority of those, the ADHD had never been diagnosed. So that reminds me of a patient I saw several years ago. He's a successful CEO. He'd start up several tech companies and run a few of them into the ground, partly because he had an explosive temper, and when we reviewed his other symptoms, which made it clear he had a whole range of ADHD symptoms, he said, oh my God, he had a little initial resistance, but by the time he came back and done more reading and mulled it over, he said that this was such a powerful, helpful insight, because, quote, I thought I was just an asshole up until now. So the other diagnostic category that Dodson points out that we shouldn't confuse RSD, rejection sensitive dysphoria, with social phobia. And certainly people with RSD may develop social phobia or intense fear of being judged, criticized, but his point is that social phobia by definition is an anticipatory phenomena where you're afraid of going into situations, you inhibit yourself, you avoid them because of the fear of being scrutinized, in addition to having intense, often negative thoughts and ruminations and anxiety in those situations. Dodson then goes on to describe that there's a couple different characterologic responses or tendencies people with ADHD develop when they're diagnosed or when they have prominent RSD. One is that many of them sort of swing the other way and try to be excessively people-pleasing. So they're trying to avoid any criticism. They try to be the best person possible, or the best friend, or the best, nicest, least don't make waves character. A subset of this can also develop sort of perfectionism, where they become obsessively worried about any small detail they may make in projects, presentations, interactions that could lead to criticism. And then an opposite response can also develop in a different subset of people, where there's they sort of adopt the framework, well, I'm just going to avoid all interactions, and I don't really try or don't really care, because anything I'm going to do is going to be criticized and met with negativity anyway. So in Dodson's formulation, the treatment for rejection sensitive dysphoria is never psychotherapy, and he says because the treatment, rejection sensitive dysphoria, he says, is a genetic and neurobiological or neurological treatment, and therefore psychotherapy won't work for it. I'm going to get back to that later. So again, one thing in terms of his evolution over the last few years seems to be he's posing this as purely a biological, neurologic, brain-based aspect of ADHD and not needing actually traumatic feedback from the environment. I'll go talk about that a little more. The next thing he says regarding treatment, again, discarding all behavioral-based, psychotherapy-based treatments, he says that the alpha agonists, so these are the drugs clonidine and guanfacine, so that's clonidine, not Klonopin, not the Klonopin, which is a Valium-like drug. Clonidine and guanfacine were originally high blood pressure medications. They're called alpha agonists. Their indirect action is to boost norepinephrine and maybe to some extent dopamine release or availability in parts of the brain, but they are not stimulants. They are not revving people up. Their acute effect is usually sedating, and they often take many days to a few weeks to work, but they often can help sort of damp down emotional overwroughtness or hypersensitivity in ADHD. And Intuniv is one of the brand name products that has been FDA approved for ADHD that's in this category. The other set of medications he promotes for this are the monoamine oxidase inhibitors, which were some of the earliest antidepressants, but which we have tended to avoid in psychiatry since the advent of SSRIs and medications that are much safer and easier to use. There is a long tradition, and in most Psych 101 textbooks, you'll read that monoamine oxidase inhibitors work better for atypical depression than for standard depression. So atypical depression are people who are depressed and tend to have overeating, oversleeping, and reaction sensitivity. So again, this theme of some people in the depressive subgroup of depression who have this rejection sensitivity that may be hypersensitive or responsive to MAO inhibitors. So the last thing I'll say about sort of Dodson's approach before I start criticizing some of it is that in some of his writings, and actually in some of he switches back and forth in the same article as to whether this is just a subset of emotional dysregulation or whether it is essentially all of what's important with emotional dysregulation. And it seems pretty clearly from a number of sentences, and I hope I'm not being hypercritical and or taking them out of context or picky, but that fundamentally he sees emotional dysregulation as the same thing as rejection sensitive dysphoria. So, sorry, I'm skipping ahead of myself a second here. Yeah, so I think the huge contribution of focus on this is it resonates very clearly with a large segment of people with ADHD. It captures something that our traditional ADHD diagnoses don't particularly do. So that's good. 2, it identifies that the emotional realm is certainly a realm where dysfunctional and distressing ADHD symptoms accrue. So so much of the title of ADHD, so much of the popular culture, and actually so much of part of formal DSM-5 description of it focuses on attention, concentration, hyperactivity. So there's a squirrel and that's all that there is to ADHD. This really gets at that is not all that's going on, that if you understand that as our current understanding that ADHD is a problem of executive functions in the brain, how the brain modulates, regulates, monitors, and controls its own awareness, its own focus, its own sustaining focus, its sense of time, its planning, its prioritization, and emotional regulation, impulse control, physical control are all part of that. And this brings up, and I think it has been neglected, and it's good that it's coming more to people's awareness. And Donald Trump, again, is a wonderful example of someone who has profound emotional dysregulation, which I argue is part of his ADHD. And we see the consequences of it every day, including, I'm sure, we'll see more outbursts today. So I'm going to segue into some of the things that I see as potential problematic aspects. Again, I think it's a good and useful concept. I don't want to throw out the baby with the bathwater, but there's a few aspects that I think really are troubling to me. So one is, again, I think Dodson in most of his writings is equating emotional dysregulation, which other people are writing about and discussing in the context of ADHD, is the same as rejection sensitive dysphoria. But emotional dysregulation clearly includes a broader range of emotions than just these two negative ones. So in ADHD, there are many people who get too elated at certain situations. You know, they see a friend at a bar or they're laughing at a joke. This is in a time pre-COVID when we could easily socialize. And they're the ones who are talking off the top of their lungs or who are shouting in excitement and knocking things over. So emotional regulation in the context of ADHD actually applies to a range of emotional expressions, not just sort of the negative, depressive sadness like or shame or anger that we are associating more clearly with ED, but even positive emotions can be out of regulation, out of control in ADHD, people getting too giddy, too silly, too crazy, too wild. I mean, how often are kids in general, but particularly ADHD kids, told that? That is all part of emotional dysregulation that I would argue is not part of rejection sensitive dysphoria. The second big issue I have with Dodson is that he says numerous times over the years that absolutely everyone with ADHD that he's ever seen, it's 100% present in people with ADHD. And he goes on to, it's often masked or hidden, it's a shameful thing, it's not a recognized thing, so people might not think to bring it up. I just don't see that. I mean, one is, and I'd say there's considerable evidence to the contrary. So one is we have something called positive illusory bias, and I'll talk more about that next week, but a third of kids with ADHD actually seem fairly impervious to negative feedback or criticism. They're sort of always moving on to the next thing. If they get negative feedback, it slides off their back. I mean, interestingly, you could see parts of this or elements of this in Donald Trump at times. But again, my own clinical experience, and even though this resonates with many people with ADHD, I think there are subsets of people with ADHD and fairly sizable ones who do not experience this as a phenomena or a problem with it. So furthermore, beyond that, I'd say particularly those who are more formally studying emotional dysregulation in ADHD tie it very strongly to the hyperactive rather than inattentive forms of ADHD. So the people with purely inattentive ADHD seem to be much less likely to have emotional dysregulation, whereas people who have impulsive hyperactive ADHD are much more likely, and some studies suggest a overwhelming majority of that subset have emotional dysregulation. So again, I do not think this is everybody with ADHD. The third thing, and again, this is one I really strongly think is not right with this, is that Dodson also defines rejection sensitive dysphoria as specific and unique to ADHD as part of the biological wiring for him. And maybe it's my own experience as a gay man, maybe it's my own experience with working with a huge range of LGBTQ people coming into their own identity and learning how to deal with rejection. But I'd say the exact feelings of being really sensitive to criticism, interpreting many things negatively, even if they may not be at some point in time, that feeling of complete disappointment, meltdown, shame, intense negative emotion, I think is actually characteristic to a whole host of people, not just gay, not just ADHD, but certainly along the whole, what we're calling now the neurotypical spectrum. And I think, again, my construct is that this isn't just a biological phenomena, but like I would argue absolutely everything in psychiatry, psychology, neuroscience, brain behavior, everything is both nature and nurture. You may have strong biological predispositions, but how you grow up, how people support you or don't support you is going to shape how your brain develops and how you wind up reacting and feeling. So I think that lots of neurotypical people experience what would look like rejection sensitive dysphoria, and many of them don't have ADHD. And I would sort of further posit that the feeling of being different, alien to other people is actually a subset of human behavior, even if you don't fit on the neurotypical spectrum. I think the very popularity of books like the Harry Potter series, I think what she actually captures is lots of kids, lots of people grow up in a family, a society, a world where they feel weird, different, and criticized for that. And until they realize, aha, I'm not really a muggle, I found my tribe, I'm a wizard, I have superpowers as well as problems according to that society. I think my feeling is that that's a major contributor to what he's defining as rejection sensitive dysphoria. So that sort of segues into my fourth objection, which I've sort of highlighted. He defines it currently right now as a purely biological process, and I think these things are, and I think the evidence would support that it's always a combination of biological, often genetic predispositions, but in an environment that pushed someone further in that direction. And that leads me on to the fifth objection I have. So the fifth objection is, he says flat out that psychotherapy can't help it because it's a biological issue. And because it happens so quickly, it comes up so powerfully, there's no chance for cognitive or emotional strategies to deal with it. And I would say on the face of that, that strikes me as remarkably wrong. And the counterexample I would just bring up is panic attacks. Panic attacks, there may be a huge overlap between panic and rejection sensitivity dysphoria. I'm not saying they are the same thing at all. What I'm saying is panic attacks, we know, have a strong biological underpinning. There is a panic center in your brain. It's being triggered inappropriately. You have a host of very physiologic changes in your body and in your brain that are going to lead you to thinking and feeling an intense state of terror. And yet, we know purely psychotherapy approaches, CBT-based therapy approaches, symptomatically can treat panic effectively, and they result in brain changes when they do treat panic effectively. So the fact, even if this RSD is purely biological, doesn't mean it can't be addressed by psychotherapy. And the study I was just reading this morning, the study was actually designed to look at parents with ADHD and how treating the parent results in behavior to the kids with ADHD. And they were actually comparing treating mothers who'd never been treated or never diagnosed before for their own ADHD with Vyvanse or with behavioral parenting training. And at least 3 different measures, and the measures they had were, you might have to think, they defined them as temper, affect lability, and lability is variability or out of and emotional overreactivity. So 3 measures of certainly emotional dysregulation, probably rejection sensitive dysphoria. And on all 3 measures, the mothers in the behavioral treatment group improved statistically on all 3 ODs, purely through behavioral. They did respond robustly to the Vyvanse as well. So that's the other thing that I'd object to, and that's my last point, is when he holds out the MAO inhibitors and the alpha agonists as the only things or the most powerful things helpful for this. And again, this is looking more at the broader range of emotional dysregulation, but including symptoms that would certainly be RSD-like. There are a number of studies that have looked at stimulant medications, which you'd say, oh my God, giving stimulants to people who are emotionally reactive. And repeatedly, and Russell Barkley has written about this and summarized it, the stimulants in an individual with ADHD, when they help with the cognitive distractibility, attentional aspects of ADHD, also are extremely likely to be found to be measurably helping with the emotional dysregulation. So, and jumping further back in time, I mean, it's a Psych 101 truism that the MAO inhibitors were selectively and especially helpful for those with reactive depression, in contrast to other antidepressants being less helpful. The more studies we have on that, the less clear-cut that there is, and a number of studies have not found any advantage of MAOI over other antidepressants for atypical, again, rejection-sensitive depression. There, to my knowledge, have not been any studies looking at RSD in ADHD context to show that MAOIs work specifically better than either stimulants or non-stimulants like bupropion or atomoxetine, Wellbutrin, or Strattera. So it may be true, but I'm not aware of any data that supports that. And in my own practice, I've certainly seen people respond well to stimulants or well to non-MAOI, non-stimulant, other approaches for ADHD where it helped the emotional component, emotional dysregulation component. And I've certainly seen individuals with on MAOIs who were specifically trying them to help with RSD who didn't get much help. So that I've gone over for my time today. Next week, I'm planning on talking about positive illusory bias. Stay well, stay healthy, and if you're in the mood to celebrate election results, do so wisely. I see there are some questions, so I will be addressing them right now. So is DBT, which is dialectical behavioral therapy, a treatment that was specifically designed for borderline personality disorder, has been studied in a range of other situations, including depression, suicidality in the context of no borderline personality disorder, and has been found to be helpful for help with emotional regulation and improving communication. I am not aware of specific studies looking at DBT for RSD, but everything I know about RSD or emotional dysregulation in the setting of ADHD and about DBT would suggest there would be likely to be an excellent and useful pairing. Again, I am not aware of hard data, but I think it's a good fit. So the second question is, I'm very scared of rejection or neglect. How do I tolerate my feelings, especially ease the compulsive reactions? So again, part of it is medications may be helpful. And I've certainly had people who had what we may say is more social phobia in response to RSD type behavior, who actually did benefit a lot from the addition of an SSRI, maybe to treat a social phobia aspect of this. I would also say that there are, I mean, the cognitive behavioral framing that I've seen to be helpful with people with ADHD and rejection sensitive dysphoria or emotional dysregulation, and it doesn't help so much to prevent these outbursts from happening, but it helps many people get out of them more quickly, and it seems to help reduce the likelihood that they will be triggered. Is telling people that a component of your ADHD is some emotional volatility, that is there built into your system. It's not something to be shameful for. And again, part of what locks people into the system is feeling they're so bad, they're so wrong, they're so beyond being helped, but actually just knowing, okay, we know this is how your brain tends to work. Doesn't mean it has to always work that way, but it doesn't mean it's you're bad or weak or shameful or defective because you are. And often just reminding people, wait a minute, I have ADHD helps them to take a step back from the situation. So almost always, not just social anxiety, but a whole host of anxiety. The problem is that anxiety is that the focus of attention becomes perceiving how well am I doing on this task rather than on doing this task. So part of the way out of anxiety states is to help redirect attention to don't evaluate myself. I'm not being tested right now. My task is to get back into the task at hand and remembering what my task at hand is. So again, that I could talk a whole another session, but I see one more question. So the last question is, I've had some success with my therapist using internal family systems. I also take clonidine at night, which would be another tactic to combine. If you can see what would be another tactic to combine. So again, clonidine is one of the alpha agonist agents that many people are promoting, and there's a little bit of study. There is some study on clonidine, on guanfacine for the broader range of emotional dysregulation in the setting of ADHD, less that I'm aware of, and specifically for RSD. So again, I'd say that the answer I was just giving about DBT with ways of helping regulate emotions, I think is helpful or likely to be eventually proven helpful, not yet proven, for emotional dysregulation in ADHD. And some of the cognitive approaches I was just saying, again, being aware you have ADHD, being aware you're going to be vulnerable to these attacks, but that knowing and rehearsing when you're not in attack that you will have an attack and you will get out of it. I mean, that's essentially the treatment for panic, is that, yes, this is bad, yes, this is scary, but no, you're not in danger, you're not about to die, is proven to help end attacks faster and decrease the frequency of attacks. So I will be back next week, and have a good week and a safe one. Bye for now.